Thank you so much, Martin. It's an honor. It's an absolute honor to be here. One walks into this building and immediately you get the sense that this is where medical education happens. It's an old building, 100 years old. I come from the first medical school in the United States, University of Pennsylvania. You too? Wonderful. No? Oh, I'm sorry. Thank you. Because I thought you wanted to come down and give my talk. No. Okay. Thank you. And please, so you are now in charge. If I begin to go like this, you just, yeah. And if anybody gets bored, just go like this. We're going to be talking about something that for me is very important. I don't know, Milton, if you appreciated that we've only been here 5 minutes and we already changed the topic, the theme of the conference, because we have this is a problem. We have a real problem, and I'm worried. You'll see that I sort of turned this into a military campaign, a call to arms. I think there is something happening here that really must receive our attention, and that is the concern that we are no longer examining patients properly. And in terms of keeping with what is new, we now have new ways to really educate people on the clinical exam. So I think this is going to fit in well. I can advance the slides with, thank you. Great. So as you see, I have no conflict, but I have a lot of concern. I am very concerned that we are about to lose something extremely important, certainly for internal medicine and for medicine as a whole, which is our ability to properly examine patients. How concerned should I be? How much of an issue is this? Well, perhaps the sky is not falling, but can there be any doubt that we, as in the year 2018, are practicing medicine with an over-reliance on costly tests, and that there are data suggesting, if not indicating, that the quality of our physical exams is not as good as they should be. And these wonderful people here, you are the teachers of tomorrow. And if you don't learn this and carry this on, I think we will have lost something extremely important. So this talk is for you. I'm not talking about the older generation. By the way, this picture is taken from my medical school reunion, our 40th reunion. I was the 6th person on the right, but I asked my secretary to crop it right there. So the older people in the audience, please listen. I'm interested to know what your comments are, but here's people I'm talking to. Because I really want to ask you, if you don't continue to know how to examine patients properly, will your rounds be as interesting as this? So I think we really have something very important to focus on. So we need a movement, and I've chosen to call it the Back to the Bedside movement. And like any movement, the first thing one needs is a tagline. And perhaps I've had a little bit too much time on my hands, but I've given some thought to what the tagline for this movement should be. And I've come up with listening to patients, directing their care. Now, taglines are always interesting. You can see here the tagline of the American College of Physicians. It's leading medicine, improving lives. And any good tagline has a double entendre. 2 questions, 2 meanings. For the ACP, everybody reads the tagline and says, leading internal medicine, improving lives. And they always ask, whose lives? The lives of the patients, the lives of the internist. And the answer, of course, is yes. The most famous tagline is Nike. Everybody knows Nike's tagline, just do it. Now, what are they talking about? Just do it. Run that 100-yard dash, buy those $200 sneakers, and the answer, of course, is yes. So my tagline is listening to patients. And here I mean listening to what patients really want. And we're going to talk about trying to get close to meeting our patients' goals for the encounter with their physician. But also, of course, listening to their hearts, listening to their lungs. And if you really get good at this, perhaps even listening to their thyroids to see if they have a vascular bruit associated with Graves' disease. And then directing their care. Truth be told, we may not be coming up with definitive diagnoses based upon bedside exam, although certainly that happens frequently enough, but at least we could direct the care. We can become more parsimonious. We could even become more elegant as we do a really good physical exam and be able to direct the further workup in a way that makes a lot of sense. Because the alternative is to practice like our friend Don Quixote, who, when called into battle, jumped upon his horse and rode madly off in all directions. And that's not what we want to do. So with that, let's begin to really talk about the reason this is so important. And I've come up with 10 reasons, and I've ranked them in order. And we're going to start from the bottom. Number 10, it connects you with medicine's traditions and luminaries. I think that's important. I think we have at least the opportunity to do something that has always been part of internal medicine, and therefore have a connection with the luminaries of the past. And I'll give you some examples. It provides a window into the pathophysiology of disease. You can really illustrate pathophysiology with your physical exam, particularly those findings that involve maneuvers. It also illuminates clinical epidemiology and the diagnostic process. We'll talk about that. It represents an opportunity to be hands-on and artistic. I'm a general internist. I don't do procedures. My colleagues don't do procedures either. But I think there's a way for general internists to distinguish themselves from others by doing an absolutely expert physical exam. And in that sense, it brings out the artistry, which is exciting. It enables you to make diagnoses more efficiently. I think that goes without saying. Patients appreciate it. Again, we will be talking about this. It enhances your performance as a teacher. I probably am standing here because throughout my career, I really have been committed to physical examination. That has accounted for whatever success I have enjoyed as a teacher, and I'm going to commend that to you as well. With all that, some of you may be thinking, well, I just don't know it. I'm not going to teach it if I'm not good at it myself. And I don't accept that as an excuse, because I know how smart people are. You can learn this. You can get good at this. Number 2 is it promotes physician satisfaction, indeed the joy in practice. And the number 1 reason why you need to join this movement is, hey, you already paid for that stethoscope. So kidding aside, we're about ready to start. But before we start, I want to take a survey. Nobody's wearing their white coats because you shouldn't. We're not seeing patients at the moment. Raise your hands if you carry a tuning fork. And just 1, 2. And so I'm not going to ask my second question. Is that tuning fork one of those silly purple or pink triangles? Or do you have a tuning fork in your pocket that looks like this? Because this is the secret sign. As those of us who are interested in physical exam travel around the country, travel worldwide, we don't have a secret handshake. We know that who we are because we carry a decent hammer for assessing reflexes. Buy one, it's worth it. Okay, here we go. Number 1, connecting with luminaries. And here's your opportunity to connect. We have Osler and Jack Ende. By the way, that's me on the right. And every time you examine a patient, you have the opportunity. You are doing something that was so important to Osler and all of his colleagues. So as you connect with him, please keep that in mind. But remember, as I always tell the medical students, examine patients from the right side. Every time you examine somebody from the left side, Osler spins in his grave. So there you are, you're on the right side of the patient, and what are you going to see? Well, you may see something like this. The way I examine neck veins is I'm on the right side of the patient. I take my right hand, I reach over to feel the patient's left carotid artery, to feel the upstroke. I look at the supraclavicular fossa. You could almost always see venous pulsations there, and I know that they're venous because I'm feeling the arteries, so there's no confusion. And I do something that I believe Kurt Wenckebach did. Back in, by the way, what's so interesting is he described Wenckebach's rhythm in 1906. The electrocardiogram was just coming into vogue. He may have done this without even relying on the cardiogram. He may have done this by physical exam. So he's feeling the carotid upstroke, and he sees, and he sees a P wave. And then he's feeling the carotid upstroke, and he sees the A wave representing atrial contracture. And then there's the A wave and a delay, A wave and an even longer delay. A wave and no carotid upstroke at all, right here. Probably turned to his nurse and said, hey, this is Wenckebach. By the way, this was so prevalent in his day. Everybody was being treated, not just digitalis, but digleaf. So who knows how much toxicity was walking around at the time. Here's another luminary, Dr. Homans, and I put this in early because I want you to know I have not totally lost my mind. I really do appreciate that not all physical findings are of sufficient accuracy for us to make decisions based upon them. And one example is Homans sign, which I'm sure you're all familiar with. Homans was not an internist, he was a vascular surgeon. He really described the association between venous thrombosis and pulmonary emboli. His treatment was to ligate the superficial femoral veins to prevent pulmonary emboli. There was no anticoagulation back then. Very modest gentleman. He appreciated midway and later in his career that Homans sign, that is just flexing the knee at about 5 degrees and then doing dorsiflexion of the ankle to see if patients report pain. That Homans sign really just doesn't have sufficient accuracy for us to use it for decision making. So he's giving the farewell address in 1947 to the American Society of Vascular Surgeons, and he makes the very interesting comment, if you were going to name a sign after me, why couldn't you have picked a good one? He never referred to it as Homans sign, he always called it the dorsiflexion sign. I couldn't possibly go too far further without coming up with a sign that's named after a woman. Those are few and far between, so all the women, young physicians in the audience, please pay attention because there's a real opportunity here. The best I can come up with was Sister Mary Joseph Nodule. It's not Sister Mary Joseph Node, it's Sister Mary Joseph Nodule. Who was Sister Mary Joseph? She was William Mayo's scrub nurse, his assistant. And she prepped his patients the night before. And of course, back then, if you wanted to make the diagnosis of pancreatic cancer, ovarian cancer, and gastric cancer, you didn't do a CT or an MRI, you did a laparotomy. So in prepping the patient, she really began to feel something, not infrequently in the umbilical area, a nodule. And she would report to Dr. Mayo before he would begin the case that this one's going to be positive, this one's going to be positive. And eventually he had to ask her, how do you know? And she told him about this nodule that she had felt, which was, if not sensitive, certainly was specific for intra-abdominal malignancy. That's the Sister Mary Joseph nodule. So we're going to move away from history. We're going to move away from communicating with the luminaries and do things that are important for medical education, even today. Pathophysiology. Everybody remember the Starling curves? It kind of was part of your life during the first and second year of medical school. We are told that patients who have a failing heart, when you increase their preload, their stroke volume does not go up, whereas a normal heart, which is on a different Starling curve, is able to augment stroke volume with increased preload, with increased venous return. You could do this in your office. It'll take you 10 seconds. What you do is you push on the abdomen. So the correct term, everybody calls it the HJR, That's a mistake. It should be the AJR, the abdominal jugular reflux. Don't push on the H. The H hurts during heart failure. So push on the abdomen and do it for 30 millimeters of pressure. Hold it for 10 seconds and see if the neck veins go up by about 4 centimeters vertically. And if they do, this has we'll be talking about likelihood ratios in a moment, but this has a likelihood ratio of 8, which means it really is pretty powerful in helping you rule in congestive heart failure. By the way, how hard is 30 millimeters of mercury? You may not have it's not intuitive. So the next time you're in practice, take the sphygmomanometer, give it a few pumps of air, close the valve, put it on the patient's abdomen, push, and you'll see the mercury column go up 30 millimeters. And that's how hard you should be pushing. This has all been very standardized. It was done by a group of cardiology fellows with just a little bit too much time on their hands. They did this test immediately before patients went into the cath lab for a right heart cath. So they're able to really correlate it. And if it turns out that it's quite sensitive and reasonably specific for heart failure. I'll get it. There we go. It also illuminates clinical epidemiology and the diagnostic process. It's a way to really begin to appreciate the importance of operating characteristics of tests. So we do this by relying upon likelihood ratios. I apologize for the definition of likelihood ratio, which is the proportion of patients with a disease who have a particular finding divided by the proportion of patients without the disease who have the same finding. Very awkward, almost counterintuitive. So what I ask you to is just simply remember that a positive likelihood ratio is the rule-in power of the test, and the negative is the rule-out power. I also want you to remember, though, and this will be on the test, that likelihood ratios are sensitivity divided by 1 minus specificity. That will come up later. Nice thing about likelihood ratios as they pertain to physical exam findings is that we can display all the findings of a particular illness, in this case, peripheral vascular disease, and we could see which ones are the most important, the most helpful. And interestingly, loss of limb hair is not a sign of peripheral vascular disease. And whenever I say this, I know that all the older gentlemen in the audience exhale. But likewise, those who have exuberant hair on their legs in no way are being, that they don't have peripheral vascular disease. What is very helpful, though, is absent foot pulses, both. It almost makes your diagnosis of PVD, whereas if pulses are present, that is very powerful in ruling out peripheral vascular disease. So we know where to focus our time, where to focus our attention. Don't fuss too much about things that have a likelihood ratio less than 3. So let me illustrate how we're talking about medical education, what's new, how we really use this in practice. So I'm going to give you a case. 58-year-old man with a 40-year pack history of smoking is evaluated for shortness of breath with exertion. And as a clinician, you know, what are you thinking? You're thinking COPD, heart failure, maybe anemia, maybe restrictive lung disease. So I'm just going to, as a clinician, perhaps you would say that he has about a 25% chance of having COPD. And that's the probability. Likelihood ratios works upon odds. You multiply the likelihood ratio times the pretest odds. So we have to convert probability to odds, which is simply odds are the number of times it happens divided by the number of times it doesn't. So 25% is 1 over 3, 33%. So the odds of his having COPD in your mind, before you've done anything more, before you've examined him, is 33%. And then you do your exam, and you find that he has sparse early inspiratory crackles at both bases. You get excited. Why do you get excited? Because this finding has a likelihood ratio of 14.6, which is definitely a keeper. Now, what are early inspiratory crackles? Well, the expert internist appreciates that there are crackles and there are crackles. Early inspiratory crackles are the ones that occur just early in inspiration. We hear crackle, crackle, and then the mid-terminate to the end of inspiration is perfectly clear. This is quite different than what you hear with congestive heart failure or restrictive lung disease, where you'll have you'll have crackles either through all of inspiration, or you'll definitely have them in the end of inspiration. It's explainable by the early inspiratory crackles originate in the large airways, and that's where the damage is in COPD. So with that, we are able to determine that he now has post-test odds of 5, and we convert it back to probability. Probability is odds divided by 1 plus odds, so 5 over 6, or 83%. Now you could either just sort of do this roughly in your mind. I carry around one of these cards. I have it laminated, and they're very handy, where you could just simply take the pretest probability. Remember, we said 25%. Take a straight edge. Like the physical exam finding here had a likelihood ratio of 14.6. Continue it on, and you see that the post-test probability is 83%. That's interesting. I mean, at that point, no stress test, no echo, probably don't even need pulmonary function tests. You have enough to start the LAMA, discuss smoking cessation with him. Perhaps too late, but it's never too late. Be sure that he's not hypoxic, and begin to manage him. And I would feel very comfortable with an 83% probability of at least initiating my plan for this patient, just based upon the physical exam. So that's how these exams, how these findings really do work. Now, remember I said it represents an opportunity to be hands-on, even artistic. And by artistic, what I mean here is it really distinguishes you as the expert internist. So let me give you another case. Nothing could be more simple than this one. It's a case of a 28-year-old woman seen in your office for routine exam. She reports recent onset of fatigue. Gynecologic history includes 2 pregnancies and somewhat heavy menses. Diagnosis? Probably iron deficiency anemia. And you would like to really know if she is anemic. Now, what are you going to do? Of course you're going to get a CBC. It costs $5 US, readily available, but it's not going to, it'll be something that'll come back the next day. But there's no urgency for this, clearly. But there are times when you want to know if a patient's anemic right then and there. Am I the only one who has sent a 72-year-old woman off for us with recent onset of angina for stress test, not appreciating that at the moment her hemoglobin was 8? I promised myself I would never do that again. So you really should be able to assess anemia right there in the office, at the bedside in the hospital, in the office, in the outpatient setting. So we want to know what physical findings are most helpful. And once again, we see the list. And here it turns out that conjunctival rim pallor has a positive likelihood ratio of 16.7. This, as we say in the US, is a keeper. If you have that, you could be pretty sure that the patient has anemia. So we need to be good at conjunctival rim pallor. But let me ask you a question. We could also do it with our card and come up with an 80% likelihood of probability of her being anemic. But here's my question. What exactly is conjunctival rim pallor? So I need your help. I want everybody, those people who wear glasses, take off your glasses. The person next to you, and go like this. Now, in this culture, Enrique, is that an acceptable sign? Because in some cultures, it is not. So go take a look. Look at the person next to you. And hopefully what you will see is a peripheral rim of redness at the palpebral conjunctiva, just where the eyelashes begin to insert. There's a nice rim of redness. If it looks like this, where the peripheral rim is pale as the bulbar conjunctiva. The bulbar conjunctiva is always pale. It's the rim that we're looking at. If the rim looks like the bulbar conjunctiva, none. you know that the patient is anemic. And that's how the test works. So here comes an important point. Let's say you didn't know that. Well, guess what? That finding that is so important and so powerful, it's not going to work for you. It's not going to work in your hands. And let me illustrate that for you. IHSS, do you call it obstructive cardiomyopathy or HOCM or idiopathic hypertrophic subaortic stenosis, all the same. Everybody remembers what that is. That's the cardiac abnormality where during systole, the left ventricular free wall butts against the septum, and if it's hypertrophy, it prevents blood from coming out. So it's subaortic stenosis. And we are able to determine that by physical exam by having the patient do a Valsalva. Big breath, strain down, and you listen for that moment to see if it gets louder. If you took a bunch of trained cardiologists and you lined up 100 patients with IHSS, hypertrophic obstructive cardiomyopathy, and you had them do their exam, these are trained, they're not going to hear it in all patients. The sensitivity is not 100%, it's 65%. That's what it is. But the specificity is very high, 0.96. That means that it's only a rare patient. 4 out of 100 will they say it's there when it's not there. For them, it's rather specific. So you remember our formula over here, likelihood ratio is sensitivity divided by 1 minus specificity. So basically, in their hands, the likelihood ratio is 16.2. Once again, very powerful. Now, let's take another group. Take University of Pennsylvania residents. They're not, and you have them examine those same 100 patients. And here they'll only hear it 60% of the time, even when it's there. They'll say it's there when it's not there 10% of the time. So what's the likelihood ratio in their hands? Well, again, it's 0.6 divided by 1 minus 0.9, or 6. This is different. And now, let's take still a third group. University of Pennsylvania third-year medical students. And they hear it only half the time, and they say it's there when it's not there 15% of the time, and guess what? This sign is beginning to become rather useless. So what's the point here? You know the expression, a carpenter is only as good as his tools? This is the opposite. The tool is only as good as the carpenter. So unless you really get good at this, you're going to get frustrated because these findings, even the ones that are touted to be very potent, are not going to work for you. So this is something that really requires your attention and I believe will account for artistry. Well, it enables you to make diagnoses more efficiently. I think that is easy. Here's a real quick case. 64-year-old woman comes to you because both legs have been swollen, particularly late in the day. She also reports shortness of breath after walking, and she wonders if she's become out of shape. She has a history of hypertension controlled with amlodipine. And you're thinking, what I'm thinking, is the edema due to the amlodipine, or does she have congestive heart failure? Her exam is normal except for the edema. So you go to examine her further. And here's our old friend, Antonio Maria Valsalva. He, by the way, was really more of an ENT physician than an intern. Certainly he was not a cardiologist. He described this famous Valsalva maneuver as a way to expel pus from patients with severe otitis media. That's what the 17th century, 18th century was all about. But you could use the Valsalva maneuver in a very interesting way right there in your office. I do it on a regular basis. It's kind of exciting. What you do is you measure the patient's blood pressure, let's say 130 over 80, and then you inflate the cuff 10 millimeters of mercury above the systolic pressure, and the valve is closed. So if the cuff is above systolic pressure, you're not going to hear any Korotkov sounds. Korotkov sounds are indicated by this orange bar over here. And then you have the patient do a Valsalva. And what happens is the increased pressure is transmitted to the great vessels, and the blood pressure, the systolic pressure, will go up. and you'll begin to hear some Korotkov sounds, even though you're above systolic pressure, because of the augmented pressure from the Valsalva. And then you have the patient hold the Valsalva, and just as you know, the venous return decreases, so the Korotkov sounds go away. And here comes one of the most exciting 3 seconds in outpatient medicine. You tell the patient to relax. And when they relax, that takes a few seconds. If they have a normal ventricle, a ventricle that can augment ejection fraction to compensate for the previous decrease in ejection fraction, they will overshoot systolic pressure, and you begin to hear Korotkov sounds again. And then you could exhale, because you know that this patient does not have congestive heart failure. A failing ventricle will not be able to overshoot. They have absence of overshoot. So if the Valsalva sounds eventually go away, they release the Valsalva, they don't come back, because this ventricle with an EF of 20% is not going to be able to do that. So that, plus your general exam and everything else, really enables you to say, this is not heart failure, I don't need an echo, which in my hospital can cost out of pocket can cost well over $1,000. Insurance plans are charged a couple of hundred, but even more so, because I think you're probably all thinking, wow, this guy Ende is really slowing me down. I have to see patients at 15 or 20-minute intervals. In fact, this speeds you up, because you don't have to order an echo. You don't have to send your patients all over the place. You don't have to report back once you get the report. It's pretty streamlined and efficient. And there's more to this than efficiency, and this list could go on. There are so many things in medicine where the physical exam is the gold standard. Certainly much of dermatology is like that, much of rheumatology, and neurology as well. We all think that all neurologists, all they do is get MRIs. In fact, the gold standard for stroke is the history and the physical exam. Sensitivity of MRI for stroke, even when it's repeated a couple of days out, 83%. I recently, missed a case of MRI negative stroke, and that was, sort of shame on me. So there's a real role here in assessing patients, and they'll appreciate it. This is one of my heroes, Walsh McDermott, first to use INH for treatment of tuberculosis, one of the grand old men of internal medicine, chair of medicine at Cornell for many, many years. And I love this quote: "When I am sick, I want a doctor who understands me as a whole person, but I also want one who understands my parts." Doctors want patients who really know clinical medicine, and they want patients to examine them. There was a study done, reported in Journal of General Internal Medicine, almost 700 patients. 125 of them, by telephone interview, perceived that something important had been left out. So frequently that was all or parts of the physical exam, and these patients turned out to be significantly less satisfied. But for me, the most interesting part of the article were the quotes, the comments from the patients. My favorite is, "He didn't listen to my heart. He didn't listen to my lungs. Hey, I'm 78 years old. Things happen." Patients want to be examined, and I'm sure many of you have had the experience of being thanked for a careful, thorough exam. It also enhances your performance as a teacher, the subject of our symposium today. And let me give you still another example. This is real. This happened just a few weeks ago. A patient of mine who I follow, he's kind of an anxious businessman, type A, if you will, called the office and reported shortness of breath for 1 to 2 weeks. So we had him come in. He has a history of mitral valve prolapse with a beautiful 2 out of 6 late systolic murmur going into and through the second sound. So with the history of mitral valve prolapse, reports shortness of breath, you do get concerned about a ruptured chordae or something, or some valvular problem. So we examined him. I had an intern with me. We do a lot of shadowing in my practice, where interns and residents just basically work with you, and oftentimes they'll sort of be with you, just right at your side when you're seeing patients, and it's an opportunity for us to talk about what we do. So he was hypertensive that day. He was worried, but he really was not in respiratory distress. His jugular venous pressure was normal. He had a negative AJR, so we're looking good. He had the murmur that he always has, no change there, no third heart sound, no edema. And I did the Valsalva maneuver, which you are now all expert in, and that was negative. You can take physical exam findings and use them serially. You could take the post-test odds from one maneuver, and that becomes the pre-test odds for the second maneuver. So you attach these serially, and you could really go a long way in ruling out or in important diagnoses. So with him, I felt more than reasonably comfortable. I was comfortable that he didn't have congestive heart failure. We don't need to get a chest x-ray, an echo. We don't need to admit him for observation. What I did do was I got a BNP. I think that's, maybe I shouldn't have, but I think it's a very appropriate test to do. But of course, it comes back the next day. But we, based upon the clinical assessment, changed his hydrochlorothiazide to chlorothalidone, made sure he understood that he should call if his symptoms worsen. I reassured him that I believe things are okay, but I want to see him next week. I want you to come back, whether you're feeling good, even if you're feeling good next week, to be sure that everything is okay. And he did, and he was indeed feeling better. I think it was the reassurance more than the chlorothalidone. His blood pressure now was doing much better. And this really, with that intern at my side, becomes a teachable moment. It shows the office assessment of congestive heart failure. It also shows the value of physical exam. I indicated this as implicit because I don't like to get on a soapbox and talk about how wonderful the physical exam is. I'd rather see that concept develop in the minds of the learner. And I think in this case, it did. I hope it did. So this becomes an important teaching tool when you're working with people one-on-one. There's so many ways to teach physical exam. One of the real heroes of the field is Abraham Verghese, who is at Stanford, who talks about the 5-minute moment where you take one physical exam and you really focus on it for your learners. It can be taught, obviously, during inpatient rounds. We developed a special system of inpatient rounds at my hospital, Penn Presbyterian. We do all of our presentations at the bedside, and that's obviously an opportunity to illustrate and teach about physical exam. So this really can become an important part of your teaching. If you are a general internist or hospitalist and hope to have teaching as part of your career, give this your attention, because these physical exam is part of every patient encounter, and it's something that is well received by interns, students, and residents. And you can get good at this. There are many opportunities to really learn about this, practice it. Come to the ACP meeting, go downstairs to the Waxman Center. The whole floor is dedicated to this. The JAMA Rational Clinical Exam Series is very, very helpful. And it really is a matter of practice, 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 and read about it. I think we don't read enough about physical exam. And if you are going to read, the place I would start is Steve McGee's book, Evidence-Based Clinical Exam. Abraham Verghese, Sal Mangione, Andrew Elder are real thought leaders in this area. Any of their stuff is good. But this is the Bible, Steve McGee's Evidence-Based Physical Exam. Soft-covered, $40 US, certainly worth it. And as I said, I have no conflict of interest, even though he's a friend. And I can't close this talk without mentioning point-of-care ultrasound. I suspect there's some exciting things happening here on using point-of-care ultrasound, including it in the curriculum, both for students and residents. Certainly that's the case at the University of Pennsylvania, and I think throughout the U.S. in medical school. It complements, it doesn't replace, but it complements the history and physical. By now you know that I'm the guy who's always looking to take that post-test odds from 80% to 90%. I think point-of-care ultrasound really does have a role here. It's particularly helpful in assessing volume status to see if the IVC collapses or doesn't collapse with inspiration. It's fast, but I say, well, somewhat fast, because to be honest, in the office, there's nothing faster than just really looking carefully at the neck vein and having the patient Valsalva. You have to get out the ultrasound and go down the hall to pick it up. It's going to add a few minutes, but particularly on the inpatient service, I think it really has an important role. We will see where this sets out in office medicine. So sign me up, and in fact, I have signed up, and we're doing 4-hour courses back at Penn, and I am enrolled. So I'm very interested to see what this adds. So let's summarize. We've been through a lot. Bedside exam connects you with Osler and Valsalva and Wernicke and Winkelbach, Sister Mary Joseph, Homan, and others. It provides a window into the pathophysiology. Students would much rather learn the Starling curve at the bedside than they would in a lecture. It's a way to underscore the importance of operating characteristic of tests and really adopt the culture of evidence-based medicine. You can distinguish yourself and become an internist artist, but by doing a good exam, it makes you more efficient, your patients will be happier. I believe it really will enhance your performance as a teacher. The people who can do this well tend to be those who get high assessments from the students and residents. And we didn't talk about the joy of its role in promoting the joy of practice, but I think it does. I really do. There's something very wonderful about using your eyes, ears, and hands to figure out what's going on. So the number one reason, who remembers the number one reason? That stupid comment, hey, you already bought that stethoscope. Let me give you the real number one reason. That is because if you do it, others will follow you. And again, you are the generation in whom everything depends. So remember, you are the role model. So my final slide, Martin, which is very consistent with all of our themes, is on how students really learn, and that is they learn by following others. So it's been a pleasure. It's been a pleasure to have this time with you. I think we may have a few minutes for questions. Thank you.
Thank you very much for your wonderful presentation. I see many people in the audience who teaches medical students, either semiology or internal medicine. But I think we will need a week to think and metabolize your presentation. But I'm going to ask the first question about the hidden curriculum. The American College of Physicians recently published a paper on the hidden curriculum. Medical students here usually have a bad perception of the hidden curriculum, bad role model, bad models. And one of the things you proposed on that paper was just go to the bedside and be aware that all teachers are role models, right?
Thank you. I appreciate the question, Milton. It really is an opportunity to underscore some of the important points that I tried to make. The hidden curriculum is, as I suspect most of you know, it's what our students and house officers see. Yeah, it's what our students. The hidden curriculum is what our students, residents, learners see. It's what's happening around them. It's one thing for the dean to issue the formal curriculum. The informal curriculum refers to the discussions between residents and students and attending and students, all of which are unplanned. But there's very few, there's no question that hidden curriculum really does shape what kind of doctor one becomes. How does it operate here? Well, if the student or the intern sees the resident, ordering echoes just because the patient is short of breath, or ordering a spine MRI because the patient comes in with back pain, and does not really do the physical exam properly, nor make decisions based upon it, that's what people learn to do. It's that little guy over there. He's watching what his senior people, his elders, his role models do. So I think this really is a way for the hidden curriculum to operate in a favorable way. Hidden curriculum is typically associated with negative things, but it also could be positive. And when young people see their more seniors, their role models, making diagnoses using physical exam, and I don't mean to just talk about physical exam, I'm talking about the history, the whole bedside assessment, doing what's most relevant clinically for the patient, then I think the hidden curriculum can work to their advantage. Other questions, please? Yeah.
You can ask either in Portuguese or in English. If you ask in Portuguese, I will translate, okay?
Hi, Dr. N. My name is Guilherme Pereira. I'm one of the chief residents here for internal medicine. Something that you mentioned that I thought that was really interesting is that providing an approach for us to sort of rescue the physical examination into our practice, right? And I think that this is something that is sort of shadowed in our practice, especially with the residents. I think that it's sort of seducing for us to discuss more complementary exams instead of the physical exam itself. And one of the strategies that you proposed was for interns and residents to shadow senior physicians. That's what I understood. So what I would like to ask you is how much time do interns and residents spend with these senior physicians? Because I think that this is something that is a very interesting proposal for us to sort of see it in practice and see it's the real value of physical exam.
Yes, thank you. Thanks for the chance to elaborate on that. And I think your thinking is right on target. What we do at my place is we have a lot of residents always have a continuity clinic where they're taking care of their own patients, typically once a week, in primary care twice a week, and then they present the patient to the preceptor. I'm sure you do something similar. But in addition, they have blocks of ambulatory care, month-long blocks. And there we have them, either one session a week or 2 sessions a week. They will be assigned to one of the more senior clinicians and shadow that person. And so it's one-on-one. And you certainly can have the learner go in and see patients himself and then present them to you. But to me, that duplicates what's happening in the continuity practice. So I always sit down with the person and say, look, you're going to have a career of 40 or 50 years. You will have so many opportunities to take the history yourself, to be the first one in the room. This is an opportunity to see how somebody else does it. So I'll sort of get their agreement, and they will be right there with me. I have a little room outside, a conference room. The patient is in the exam room. I'm there with the house officer in the conference room. I'll tell them about the patient, and I'll tell them we're going to go in, and here's what we're going to be focused on. And we'll do the exam together. I will always have them repeat the findings, with the patient's permission. They'll be right there at my side. And then we come out, and I dictate my notes as well as doing them electronically, and we'll be able to talk about the physical exam and the physical findings. What they see there is how a more senior person works quickly, cuts corners, doesn't do the full history and physical, and in my case, and I'm sure in my colleagues' cases, are able to illustrate the physical exam. That intern who was with me for that patient with mitral valve prolapse and shortness of breath, he was one of our interns and was shadowing me. So we take a minute or two and we talk about it between.
What's your opinion about the choosing wisely movements? Because when people ask it, a lot of medical societies to define 5 things people and physicians should know, almost 100% of the things were do not order. They seldom say order this or do it.
What a very, it's a creative way. It's a very creative question. The, what Professor Milton is referring to is the American Board of Internal Medicine Foundation started this Choosing Wisely campaign. Every specialty, and I think they're now up to 40 or so, have identified 5 things that we shouldn't do in an attempt to provide high-value care and eliminates that waste, which some people believe accounts for 20 or 30% of medical expenditures. The 5 things for internal medicine, I'm not going to remember them, but they certainly include doing the preoperative exam for simple surgery like cataract surgery. They include ordering imaging, radiology studies when patients present with acute back pain, antibiotics for upper respiratory infections, and maybe somebody remembers there are 2 other things. You are correct. They don't say do, they just say don't. That's why we need this campaign. Great. Thank you.
I would like to know
Yes.
what you think about our synthesis in graphic recording about your presentation.
I mean, about the, I think it's spectacular.
Yes.
I absolutely do. And by the way, the Annals of Internal Medicine, I don't know if people follow the Annals, does things like this. They are now having illustrated articles. They're having images that go along. They have a form of abstract, rather than the abstract in words, but in diagrams and pictures. So this is truly remarkable. However, I'm going to take back everything good that I said. What's wrong with this picture?
Well,
What's that? No. The doctor's, oh, no, I think she's on the right side. Actually, I think she's standing between his legs, but I think. Now, what else is wrong with this picture? Got the shirt on, yeah. So Osler right now is still spinning. And you could tell who is committed to this by always being sure that patients disrobe. Disrobe respectfully, it can be done properly. We don't have time to talk about that kind of thing. But, and by the way, I am teasing. These are wonderful. But if you're part of the movement, your patients will be undressed.
I'm going to ask you another question. To be honest, we teachers, I'm trying to be honest. We teachers of internal medicine can do a lot of things, but one thing we have not been able to do, both for medical students and for residents, is to convince them to order less exams. It's very, very difficult for us, and we have been very frustrated about this.
We share your frustration. It's and there's so many reasons for it. One is the pressure to move quickly to get the patient through the hospitalization, and the belief that I'm going to need that head CT. Let me go order it. I think, and there have been many interventions that have been tried, providing feedback on the cost of care. Actually, nothing has worked well. I think it's going to have to come from the senior people, calling this out. Maybe we should adopt, in a very nice way, in a very friendly way, zero tolerance for ordering too many tests, and not just assume that that's the way it is. We have to make that point clearly, and we have to be examples of how medicine should be practiced.
Thank you very much.